It's back for chapter 54. There's a lot of material to cover for this one. I'll try not to be all over the place. Once again, though, whatever I do not mention here, I will be going over in lecture. Here are your learning objectives. Okay, so to start out with kidney disorders, just to be a little more in depth, the fluid and electrolyte imbalance needs to be assessed and really paid attention to. The most accurate indicator of fluid loss or gain in patients who are acutely ill is weight. And that's why they stress it so much in the hospital when you're doing admission and when you're doing daily assessments. And as far as how important it is, 1 kilogram of weight gain is said to be equal to 1,000 mLs of retained fluid. So that's why with these patients, it's so important. There is a table in your book, 54-1. I know you guys hate these tables, but it's a really good table. It goes over a lot of the fluid and electrolyte disturbances. There's also 5 stages of kidney disease. The stages are based on the glomerular filtration rate. It's stage 1 through 5. Now with stage 1, kidney damage is as far as the GFR, it's normal or increased. With stage 2, it's a mild decrease in the GFR. With stage 3, moderate decrease. Stage 4, severe decrease. And then stage 5 is end-stage kidney disease or chronic kidney disease. Stage 5 results when the kidney cannot remove the body's metabolic waste or perform its regulatory functions. That's why it's so important to do screenings and early interventions as soon as possible. There's a lot of younger kids that suffer from kidney disorders that if they were screened and properly assessed when they started showing signs and symptoms, their kidneys could have been saved if proper interventions were implemented. Causes of acute kidney failure, we have hypovolemia, hypotension, reduced cardiac output, and heart failure. That decreased circulation really messes with the function of the kidney. Obstruction of the kidney or lower urinary tract, any type of obstruction, whether it's a tumor, a mass, a stone, obstruction of renal arteries or veins, from calcification, clots, tumors, or scarring. And causes of chronic kidney failure. The primary cause of chronic kidney failure is diabetes. All the secondary leading causes are right underneath. Hypertension, chronic glomerulonephritis, pyelonephritis, obstruction of urinary tract. It could be hereditary lesions, vascular disorders. And then, of course, the ones that we could easily prevent is the medications or toxic agents. That's why it's so important to monitor medications on these patients as well. With chronic or with the chronic kidney disease and acute kidney injury, these patients they'll have elevated serum creatinine levels. As the creatinine level increases, the symptoms of the chronic kidney disease will start to begin. anemia, metabolic acidosis, and abnormalities in calcium and phosphate start the development of CKD. The fluid retention, evidence of both edema and congestive heart failure develops. And as the disease progresses, abnormalities in electrolytes occur, heart failure worsens, and hypertension becomes more difficult to control. It's always worse when we get so far along that we can no longer reverse the effects. Glomerular diseases. So there's the acute nephritic syndrome, glomerulonephritis, which can be chronic or acute, and the nephrotic syndrome. With acute nephritic syndrome, this is a type of kidney disease with glomerular inflammation. And as far as glomerulonephritis, this is an inflammation of the glomerular capillaries that can occur in acute or chronic forms. And then the nephrotic syndrome, this is a type of kidney disease characterized by increased glomerular permeability and is manifested by massive proteinuria. These diseases destroy the glomerulus of the kidney and are the third most common cause of stage 5 chronic kidney disease. The glomerulus is within the nephron, and this is where the unfiltered blood is filtered and then returned to the circulatory system. Okay, next, acute nephritic syndrome. Like I said before, it's a type of kidney disease with in which there's glomerular inflammation. The primary glomerular disease include post-infectious glomerular nephritis, rapidly progressive glomerular nephritis, membrane proliferative glomerular nephritis, and membranous glomerular nephritis. Ooh, say that 5 times. Manifestations are hematuria, edema, azotemia, proteinuria, and hypertension. May be mild or may progress to acute kidney disease or even death. Medical management includes supportive care, dietary modifications, treating the cause if appropriate, and then suggestions as far as the appropriate treatments are antibiotics, corticosteroids, and immunosuppressants. Let's see. Nursing management for acute nephritic syndrome. Always going to be patient assessment. Remembering to pay attention to maintenance of fluid balance, fluid and dietary restrictions, patient education, and then follow-up care, which is where a lot of the patients mess up and they don't follow up and continue that that self-care at home. Some of the complications, let's see, for acute glomerulonephritis include the hypertensive encephalopathy, heart failure, and pulmonary edema. And then the other stuff that I kind of mentioned, the rapid progressive glomerulonephritis, which is characterized by a rapid decline in renal function. Let's see. As far as like diagnostics, in acute nephritic syndrome, the kidney becomes large, edematous, and congested. All renal tissues, including the glomeruli, tubules, and blood vessels, are affected in varying degrees. If the patient improves, the amount of urine increases and the urinary protein in sediment will diminish. Some patients develop severe uremia within weeks and require dialysis for survival. Let's see. Before I move on to glomerulonephritis, medical management for acute nephritic syndrome consists primarily of treating the symptoms, attempting to preserve kidney function, and treating the complications promptly. And that's going to be pretty much for any disease process. Always treating symptoms and then any other complications that occur. Okay. Glomerular I can never say these words. Glomerular nephritis. Sorry, guys. So, with this one, it may be due to repeated episodes of acute nephritic syndrome, hypertensive nephrosclerosis, hyperlipidemia, chronic tubulointestinal injuries, and hemodynamically mediated glomerular sclerosis. Let's see, renal insufficiency or failure. Abnormal laboratory test results will be urine with fixed specific gravity. There'll be casts, proteinuria, electrolyte imbalances, and hypoalbuminemia. Medical management determined by symptoms. Just like I stated before with everything else. The kidneys are reduced to as little as 1/5 their normal size in this when they're in this chronic glomerulonephritic stage. The clinical, let me see, is it the clinical the clinical management for most of these patients are going to be, like I also stated, the general symptoms are usually treated, and those could be such as weight loss and loss of strength, increasing irritability, an increased need to urinate at night, headaches, dizziness, and digestive disturbances as well. As far as assessment and diagnostic goes, urinalysis reveals a fixed specific gravity, variable proteinuria, and urinary casts. Pretty much everything that I already just mentioned. Just trying to add in some of the stuff that I had already had so you guys don't have anything left out. Let's see. Nursing process is always going to consist of assessment first, managing potential fluid and electrolyte imbalances, cardiac status, neurologic status, emotional support at any time whenever you can provide it, and then education and self-care. Because this self-care is what will determine the patients that will actually do well after being provided care. Let's see. Nephrotic syndrome is next. It's a type of kidney disease characterized by increased glomerular permeability and is manifested by massive proteinuria. Clinical findings include marked increase in protein, a decrease in albumin in the blood, diffuse edema, high serum cholesterol, and low density lipoproteins. Nephrotic syndrome is caused by glomerular damage. And with these patients, medical management is going to include drug and dietary therapy. Here's a little picture that goes over the sequence of nephrotic syndrome. I believe this one is in your book too. Just read through that when you get the chance. You may not really understand it, but if you ever come back to it, it'll make more sense later. All right, let's see. Next, we are going into kidney failure. This unfortunately results when the kidneys cannot remove waste or perform regulatory function. A systemic disorder that results from many different causes. Acute kidney injury is reversible, and that results in decreased glomerular filtration rate and oliguria. And then chronic renal failure is a progressive, irreversible deterioration of renal function. So just remember those two. Acute kidney injury is reversible. Chronic failure that progresses is irreversible. Okay. The care of the patient with chronic kidney disease and acute kidney injury, I kind of went over already. Let's see. Fluid status, nutritional status, patient knowledge, activity intolerance, self-esteem, and then the potential complications. Let's see. Excess fluid volume, imbalanced nutrition, deficient knowledge, risk for situational low self-esteem. All of this is going to be a part of the care of the patient in the nursing process. All right. Let's see. Before I go into collaborative problems and complications, there are phases of the acute renal failure, and just make sure you guys look back at those. You have the initiation phase, which begins with initial insult, the oliguric phase, accompanied by rise in serum concentration of substances. Urinary output will decrease at that phase and also may last 1 to 3 weeks. And then there's also the diuretic phase. The kidneys begin to recover. And then the actual recovery phase, the tubular function is restored and diuresis subsides. I'll cover more of that too in lecture. Okay, so now collaborative problems and complications. Most of these here are the complications that can occur with both of these phases. It's kind of a repetitive repeating of all of this stuff because they're pretty much mentioned with all of the disease processes. The number one thing is just knowing how things can be prevented and what to look for. All this is going to be part of your assessment and diagnostics. The care of the patient with chronic kidney disease and acute kidney injury planning. These are just the goals that you will have as far as maintaining any excess fluid, maintenance of adequate nutritional intake, continued education, participation in activity within their tolerance, whatever they can do, improve self-esteem, and then absence of complications so that they will eventually be able to go home and hopefully not have to be readmitted. These patients are constantly readmitted back to the hospital. Okay. Excess fluid volume. Assess for signs and symptoms of fluid volume excess. Keep accurate I's and O's and daily weights. Limit fluid to prescribed amounts, so that way you can better calculate the volume going in. Identify sources of fluid. Anything as far as IV fluids, oral fluids, even when you're just giving sips of water with medication, all of that counts. Just as well as what it counts for what fluid comes out. That includes if they vomit, if they have diarrhea, if they sweat, when they urinate. All of that is fluid that's coming out, and that has to be counted as well. Explaining to the patient and family the rationale for fluid restrictions. That's one thing that you really will have to constantly talk to the patient about, just so that they understand why their fluid is restricted, and that way they can kind of monitor themselves as well when they are drinking, and being conscious of to only drink a certain amount. Most of the time, we'll only put a certain amount of fluid in their reach, so that way they can remember that this is all you have. So you have to pretty much kind of pace yourself when you're drinking. Assisting the patient to cope with the fluid restrictions, and then providing or encourage frequent oral hygiene, because for some of them, they will feel like their mouth is dry, like they're really dehydrated, and they just have to understand and get used to the fact that right now, this is why your fluid is restricted, and it's for your safety. Imbalanced nutrition assessment. Nutritional status, weight changes, laboratory data, nutritional patterns, history, preferences. Providing food preferences within restrictions. That's very helpful, because for many of them, they don't like their the food that's listed and what they can have. So just giving them all of the preferences that they can choose from will help them to stick with that provided dietary restrictions a little bit easier. Encouraging high quality nutritional foods. And then for the stomatitis or anorexia, modify intake related to factors that contribute to alterations, and adjust medication times related to their meals. So that way, whatever medications that may cause, stomach upset, you can make sure that they're taking them with their meals. And also, too, you're making sure that whatever medications they're taking will interact with eating, because some medications are supposed to be taken with meals and some are supposed to be taken without. So just remembering which medications are for each of those. Let's see. Risk for situational low self-esteem. This is a huge one. Just remember to assess patient and family responses to the illness and treatment. Assess their relationships and coping patterns. And sometimes you have to just talk to the patient, because they won't really open up to you until they trust you. Encourage open discussion about changes and concerns, just so that they know they have a voice. They do have a say in certain things. Explore alternate ways of sexual expression. Discuss role of giving and receiving love, warmth, and affection. Renal replacement therapy, hemodialysis. The use of renal replacement therapy becomes necessary when the kidneys can no longer remove waste, maintain electrolyte, and regulate fluid balance. The main replacement therapies include the various types of dialysis or kidney transplantation. Types of the dialysis include hemodialysis, CRRT, or peritoneal dialysis. With hemodialysis, it's used when The patient is acutely ill until the kidneys resume function, and then for long-term replacement therapy in CKD and end stage. The objective is to extract toxic nitrogenous waste from the blood. Their vascular access will be arteriovenous fistulas or an arteriovenous graft. And the graft is usually only done if they, for some reason, can't do the fistula, because the fistulas are usually the better way to go. Here's a little picture of the hemodialysis system. And this is just showing the vascular access with an artery and a vein. Okay, I'm going to stop the video here at hemodialysis systems, and I'll restart another video at this point.